think we should start. Is that right? Okay. Yes. Okay. Good morning. And I would like to thank you all, everybody interested in the webinar. This is a part of the series of webinars by the ERN GUARD-Heart, which is the reference network in Europe on rare inherited and rare cardiac diseases. We have the topic today is we have the opportunity to hear from the chairs of the new guidelines on management of cardiomyopathies, which is the first guideline produced ever by the European Society of Cardiology on cardiomyopathies, specific cardiomyopathies, all different from pediatric to adult. That is, which is quite different from previous guidelines. And I would like to introduce Elena Arbelo, who is the first author and the chairman of the document, who will present the general overview of the guidelines. Elena is a cardiologist from the Hospital Clinic of Barcelona, and she is a very active clinical investigator and clinical in the field of cardiomyopathies and channelopathies, and she has produced several different, being author of different guidelines, and is the chairman of this very nice document. Thank you, Elena. You please start, and we will continue with Juan Pablo Casqui.
Thank you, Juanra. I'm very happy to be here. And Juanra is also a very humble person, but he's also part of the guideline. He was a very pivotal person, together with Alexandros Protonotarios, as they were guideline coordinators. So they helped both Juan Pablo and myself a lot. We were an incredible task force. The idea today is to give you some brief insight on the cardiomyopathy guidelines. Of course, with the time that we have, we won't be able to go much into detail, but we wanted to highlight a couple of key aspects of the document. Okay, these, of course, wouldn't have been possible without the collaboration with many great experts from the field, as you can see, from different countries. Many of them are members of our ERN. And also, we had more than 100 reviewers worldwide, including patients. We had a patient on the task force, and we also had patients in the review process, which was very enlightening. I think it was good for the guideline and good for the overall outcome of the paper. These are both our disclosures. And then, of course, you are working in the field, so I do not have to tell you that this is the first international guideline that covers all cardiomyopathies. We had previous papers at the ESC. We had the 2014 document guideline for hypertrophic cardiomyopathy, and then there's the 2020 ACC American Heart Association guidelines on hypertrophic cardiomyopathy, but all of the others were never covered in any international guidelines. So that's an innovation. In the guideline, we have about 45% of the recommendations are class 1 and 35 2A. But most importantly, as you know, this is mostly rare diseases. So a lot of the evidence is observational data or expert consensus. So that's why we have about 65 2/3 of the recommendations have a level of evidence C, which includes small studies or expert opinion. Now, I'm sorry, I'm touching something which I'm not supposed to. I'm sorry. Okay. I'm just not. Okay. So basically, this is the central figure of the guideline, and the thing that we want to highlight overall the whole document is that we have to think about cardiomyopathies, and that this cardiomyopathy mindset goes from clinical suspicion to a structured evaluation process that leads us to a more etiological diagnosis and this will allow us to handle it more specifically. And the guideline is distributed in such a way. The idea is that we have the patient in the center, and we start from the clinical suspicion throughout the whole process of diagnosis and disease characterization, management, both with general principles and then some disease specific recommendations. Very importantly, as Juan Ramon has highlighted, the whole document is focusing in the overall concept of the patient and the family. As you all know, in these diseases, the patient, once he's diagnosed of a cardiomyopathy, then it has to trigger family screening, but at the same time, family evaluation will also feedback the loop and increase our knowledge and allow us a better characterization of the disease in the program. And also from the pediatric, also the pediatric ages to the adulthood. So you will see that the document is covering both aspects all over. The idea is that we start with a clinical suspicion, either because the patient has symptoms or there's an incidental finding on an echocardiogram or an electrocardiogram, or maybe we have the patient coming to us because he's undergoing family screening. And the first step that we have to do in these patients or individuals is to characterize. And the first step is see morphology and function. And when we talk about morphology, we're talking about size and of the hypertrophy and dilatation or not, but also the presence or not of scar. And in every patient that we suspect a cardiomyopathy, we have to evaluate a whole lot of additional traits. These additional traits will help us in two ways. One way is know better what might the underlying disease be, and I will get into a little bit of detail later on, but also will allow identifying other possible members at risk. So all patients with suspected cardiomyopathy need to be evaluated for the presence of conduction disease or arrhythmias, of course, pedigree analysis and family interrogation, evaluate genetic testing and the possibility of extracardiac involvement lab or pathology. With that, taking into account the morphology and function, we will be able to classify, and it's not a classification, a final classification of cardiomyopathy. What we are aiming in this guideline is that we just described the cardiomyopathy. We put the patient in a box. The box can be hypertrophic cardiomyopathy, dilated cardiomyopathy, non-dilated left ventricular cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, or restricted cardiomyopathy. And the idea is that these boxes are not final diagnosis. We have to include in the considerations all the additional traits to actually end up with a more etiological based diagnosis. The guidelines is structured this way, and then you will see that there's some general management principles and phenotype specific management. This is what I summarized here. So a general approach, and we evaluate the patient considering the patient pathway, and then we discuss the specific cardiomyopathy phenotypes, and at the end you will see there's a whole lot of other relevant aspects for patients with cardiomyopathies that include sports, reproductive issues, non-cardiac surgery, and other stuff like requirements for cardiomyopathy units, sex difference, etc. So if we start with the definition, basically a cardiomyopathy, you all know it, but just to specify what we have in the guideline, is basically a myocardial disorder where the heart muscle is structurally or functionally abnormal in the absence of significant coronary artery disease, hypertension, valvular disease, or congenital disease. This doesn't mean that if you have coronary artery disease, you cannot have a cardiomyopathy. It has to be proportional. You may have mild or small coronary alterations, and if you have a significant hypertrophy, this not be justified one for the other, and you may still have a hypertrophic cardiomyopathy. As I mentioned, the starting point of the whole process is to characterize, and the first thing is usually to evaluate morphology and function. And as I said, I'm sorry, I thought I had an arrow here. Basically, the important thing is that on top of evaluating hypertrophy and dilatation, we evaluate the presence of scar, and you will see how relevant the CMR has become in the cardiomyopathy guidelines, and also, of course, the presence of systolic or diastolic dysfunction. Regarding epidemiology, it's difficult to say. There's a table in the guidelines where you will see the estimated prevalence, both in adults and in children. The important thing is that there are some special populations that need to be considered, and that they should act as red flags, let's say, to evaluate possible genetic or familial predisposition to any of these, including the alcoholic cardiomyopathy, cancer therapy-induced cardiomyopathy, peripartum, acute myocarditis, or when we have left ventricular hypertrophy and HCM, we have to suspect Anderson Fabry, or in severe aortic stenosis, we may also, there's an increased incidence of amyloidosis, and we may think about this. Very importantly, in the guidelines, we are aiming for the classical concept of heart team multidisciplinary care. One of the main aims of the document were to, given that some of the cardiomyopathies, hypertrophic cardiomyopathy, for instance, are not as rare, and also that some of them are being seen outside our super specialized units, what we wanted to achieve with this guideline is some structuring of the evaluation of these patients, that all patients have access to high standard quality care. And this includes that the pediatric and adult cardiologists know how to manage cardiomyopathies, and then our centers, so the super specialized centers from the ERN, should probably act more as referral centers for complex decisions in terms of diagnosis, risk stratification, or management, or specific surgeries needed. Some high quality care, but however it is done, all patients need to have access to all of this different specialties. You all know about it, that there's the patient part, which includes the psychological support, the family care to the patient and the family, and carers and patient associations. And then within the cardiomyopathy specialists, we need to have collaboration between adult and pediatric services. There should be a specialized nurse and, of course, genetic counselors. And then we need to collaborate closely with other cardiology specialties like imaging, arrhythmias, heart failure, etc. And of course, cardiac surgeons, geneticists, pathologists, etc. This I already highlighted, the importance of evaluating also the additional traits, which will then allow us to come to, so we have the phenotypes, we evaluate the additional traits, and we will end up with a more phenotype-based but a more etiological diagnosis that will help us tailor better the management of these patients. So all of these patients should undergo, with a class 1 recommendation, a multi-parametric approach that it requires clinical evaluation, pedigree analysis, ECG Holter monitoring, some lab tests. You will see there's some first line and second line lab tests and multimodality imaging. And when we're evaluating them, at least a 3 to 4 generation family tree is recommended with a class 1. In the guidelines, I'm not going into details because it's too specific, and you will have the chance of looking at the document, but there's very nice tables by phenotype of different characteristics that should trigger or red flag some specific diagnosis, like inherited patterns or specific signs and symptoms, or extra cardiac manifestation, ECG features and lab results. With that, you may allow to reach a more specific diagnosis. Most of the people connected here are highly specialized, so I don't need to go into detail. Very importantly is that when we have a clinical suspicion of cardiomyopathy, we have to integrate the clinical information together with the multimodality imaging. One informs the other. And it's not necessary that we perform all tests in every patient, but definitely echocardiography is recommended at diagnosis and at follow-up, and the CMR. And then we may tailor specific, depending on the phenotype and the suspicion, the other possible tests. The multimodality imaging, as it says, it allows diagnosis and ruling out phenocopies and identifying the phenotype better, but also risk stratification and prognostication and follow the disease progression. The key, one of the key elements as the reason that the guidelines were published now is precisely the increase in the number of, or the availability of CMR, cardiac magnetic resonance, together with genetic testing. And the truth is that now it has become a very important tool in the evaluation of these patients, and that's why at initial evaluation, every patient with a suspicion of cardiomyopathy needs a CMR. Then considering follow-up, the recommendation is 2A, and it really depends on the different types of cardiomyopathy, but in general, to monitor disease progression, risk stratification, it's recommended with a class 2A, and in specific for therapeutic response, to evaluate therapeutic response in different inflammatory and deposit cardiomyopathies, as you see in this recommendation. For families, the recommendation of performing serial or CMRs is nuanced by the presence of a lightly pathogenic or pathogenic variant in the patient itself. If we have a pathogenic variant, then we need to perform the CMR. It's a 2A. If we don't have the variant, the recommendation is that it could be considered, but it's not, let's say, mandatory. Of course, you all know that the CMR is very useful to characterize, not only say if there's scar or not scar, or if there's dysfunction, dilatation, etc., but also to, depending on the different phenotype groups, you may have patterns of gadolinium enhancement, or different T1, T2 times that will allow a more nuanced, more specific diagnosis. The genetic testing is the other key test of our guideline. And I don't have to go into detail for you, but you know that in cardiomyopathies, we may have these different genetic architectures where we may have, let's say, in 40% of hypertrophic cardiomyopathy, 30% of dilated cardiomyopathy, we may find a classical monogenic inheritance pattern, while the rest may be either an accumulation of variants of intermediate effect or multiple common variants that will end up provoking a phenotype. In this case, as you know, the familial cases are rarer, or there's lower familial aggregation. Genetic test is useful in the proband for diagnosis, prognosis, therapy, and reproductive advice. So for instance, diagnosis, prognosis, you will see later on in other presentations that depending on the underlying genetic alteration, the risk of sudden cardiac death may vary, or the risk of progression of the disease. Anderson Fabry, for instance, has a specific treatment. So if you have a proper diagnosis, you will be able to treat appropriately. And then, of course, reproductive advice. For relatives, those that do not carry a pathogenic or likely pathogenic variant can be discharged and reassured, while those that are carriers it will trigger a closer follow-up and early detection of the phenotype if developed. So in patients with cardiomyopathies, genetic test is a class 1B recommendation. All patients with a diagnosis of cardiomyopathy needs a genetic test. In terms of family screening, if we have a confident genetic diagnosis, we need to offer genetic testing to the relatives if adults, and it should be considered. So that's class 1 in adults and class 2A in children. Of course, you all know this, but basically when we're considering genetic testing in general, but in particular with children, there's multiple aspects that need to be taken into account that are summarized in this figure. But the ultimate goal with appropriate genetic counseling is that if the patient agrees to undergo, agrees to undergo cascade genetic testing, then, as I said, those that are genotype positives are going to be followed up more appropriately, and you're going to reassure that those that are negative. Of course, if there's not a confident genetic diagnosis, we should not perform a genetic test in the relatives, and then we may, or we should consider evaluating if the variant segregates with a cardiomyopathy phenotype in case of variants of unknown significance, always with appropriate genetic counseling. Genetic counseling, as I've been mentioning, covers many different aspects, and these are explained in the guideline. I will go into detail, but as a class 1, genetic counseling should be provided by an appropriately trained healthcare professional, and it should be done, so genetic testing should be done within the appropriate multidisciplinary team and the appropriate counseling. So now moving to the more general aspects of management, there's in this section you will see there's many different things that are basically summarized in the recommendations of other guidelines, but focusing on patients with cardiomyopathies. You will see there's a section on assessment of symptoms, heart failure management, management of atrial and ventricular arrhythmias, implantation or the device therapy, and then the routine follow-up of patients. Talking about follow-up of patients, as you know, we do this in everyday clinical practice, but basically you do the genetic test in the proband. If you don't find a variant, you have to do cascade clinical screening and follow up patients. Those with a phenotype you treat as patients, you follow the patient pathway. Let's say if they're normal, you need sporadic evaluation in the follow-up. Ideally, we find pathogenic or likely pathogenic variant, and as I said, those that are negative can be discharged, and those that are positive need follow-up, basically. Also important, all these patients need to have psychological support with appropriately trained health professionals, and this is a class 1. Patients need to have access to this. And in general, those patients, if they had a sudden cardiac death of a family member, or if they are to receive an implantable cardioverter defibrillator, and excluding those, they should also be considered for any patients with an inherited cardiomyopathy. I will stop here because my co-chair in the guidelines, Juan Pablo Casqui, is the one that will be discussing the highlights of the different phenotypes and their specific management and risk stratification. Thank you.
Thank you very much, Elena. It is very challenging to try to summarize 120 pages length, and one is the work from nearly 2 years of different people involved, with the participation, special participation and representation of different ERN centers. I think we move to the presentation of Juan Pablo Casqui, who is a cardiac pediatrician and is a leader in the field of cardiomyopathies from a very high volume and highly referral center in London. And we will discuss later, after the presentation, we will have open discussion for anyone who wants to make comments or questions to the guidelines, and we will discuss this. Juan Pablo cannot, unfortunately, will not be involved in the discussion, but there will be Elena and myself trying to answer the question or try to guide the comments. Thank you very much.
Thank you very much indeed. It's a real pleasure to be here. I'm just sorry I can't be there live. My name is Juan Pablo Kasky. I'm a professor of pediatric inherited cardiovascular medicine at UCL and consultant pediatric cardiologist at Great Ormond Street Hospital. And I had the honor of co-chairing the 2023 ESC guidelines for the management of cardiomyopathies together with my colleague Elena Aravela from Barcelona. And we've already heard Elena talk about the general aspects of the guideline, and I'm going to focus now on the recommendations that are specific to the individual phenotypes. You've already seen this illustration, which is the central illustration from the guideline, and this really highlights this concept of a patient pathway that has a cardiomyopathy mindset at its core. So the idea here is a diagnostic workflow that takes information from lots of different phenotypic traits, including the cardiac, morphological, and functional phenotypic traits to end up with a phenotypic description of the cardiomyopathy phenotype, and from there move on towards a more etiology-specific diagnosis. And the focus of this bit of the webinar is going to be on the disease-specific or phenotype-specific management recommendations. And just to start off with, for hypertrophic cardiomyopathy, this is the only one of the cardiomyopathy phenotypes for which there were existing guidelines. And so in this 2023 guideline, what we have essentially done is provided a focused update on the 2014 management of hypertrophic cardiomyopathy guidelines from the ESC. Now, much of the, many of the algorithms and recommendations for symptom assessment and management remain largely unchanged from 2014, but where we do see significant changes is in the recommendations for the medical treatment of left ventricular outflow tract obstruction. And here we have brand new recommendations related to the use of cardiac myosin inhibitors, so mavacamten in particular. So there's a new 2A indication that mavacamten should be considered in addition to beta blockers or calcium channel blockers, such as verapamil or diltiazem, in symptomatic adult patients with resting or provoked left ventricular outflow tract obstruction. And the second class 2A indication also, that mavacamten should be considered as monotherapy in symptomatic adult patients with left ventricular outflow tract obstruction who are either intolerant or have contraindications to standard medical therapy. And so this is the new algorithm for the management of symptomatic left ventricular outflow tract obstruction. We retain the class 1 recommendation for the use of beta blockers, calcium channel blockers, verapamil and diltiazem, but now there's the option of considering mavacamten as a second-line therapy, as an alternative to disopyramide. And of course, in patients who remain symptomatic despite maximal medical therapy, septal reduction therapies remain as a class 1 indication. Most of the recommendations for septal reduction therapy themselves, again, are largely unchanged from 2014, but I just want to highlight a couple of novelties here. First of all, we have a new class 1 recommendation that septal myectomy specifically, rather than alcohol septal ablation, should be recommended in children who have an indication for SRT, as well as in adults who have an indication for SRT and other lesions that require surgical intervention. And secondly, a new recommendation, class 2B indication, that sexual reduction therapy in expert centers may be considered as a class 2B recommendation in individuals with lesser degrees of symptoms, so NYHA functional class 2 symptoms, who also have either moderate to severe mitral regurgitation related to SAM, or atrial fibrillation, or moderate to severe left atrial dilatation. Now, the prevention of sudden cardiac death, particularly primary prevention of sudden cardiac death, is an essential aspect of the management of all the cardiomyopathy phenotypes. And in this new guideline, starting off again with hypertrophic cardiomyopathy, we retain the class 1 recommendation to use the HCM risk SCD calculator as the method of estimating risk of sudden cardiac death at 5 years in adult patients for primary prevention. But we have a new recommendation, class 1, that validated pediatric specific risk scores, for example, the HOCM risk kids model, are recommended as the way of estimating sudden cardiac death risk at 5 years in children, so individuals under the age of 16. And this is both at baseline, but also during follow-up. We also have a number of additional new recommendations for primary prevention in hypertrophic cardiomyopathy. So in patients with left ventricular apical aneurysms, we have a 2A recommendation that decisions around primary prevention, ICD implantation, should be based essentially on the assessment of risk using validated risk models, HOCM risk sudden SCD, HOCM risk kids, and not solely on the presence of the left ventricular aneurysm. And in patients with a low estimated 5-year risk, so those with an estimated risk of less than 4% at 5 years, there are 2 new recommendations, both class 2B, suggesting that the presence of extensive late gadolinium enhancement on cardiac MRI, or the presence of systolic dysfunction, so ejection fraction less than 50%, may be considered as part of that shared decision-making process around ICD implantation. But importantly, acknowledging that we really lack robust data on the impact of these additional risk factors over and above what's obtained from the personalized, validated risk prediction models. And so here's the new flowchart, the new algorithm for primary prevention of sudden cardiac death in hypertrophic cardiomyopathy. So as before, individuals with an estimated 5-year risk of 6% or above, considered high risk, have a class 2A indication for ICD implantation. Again, as before, individuals with an intermediate 5-year risk, so between 4 and 6%, have a class 2B ICD indication, so ICD may be considered in this context. And for those with a low estimated 5-year risk, so less than 4%, in the presence of extensive late gadolinium enhancement or systolic dysfunction, there is now a new class 2B indication here. And of course, for secondary prevention, ICD implantation remains as a class 1 indication. Importantly, though, these validated tools should be used really as part of a shared decision-making process rather than as an absolute requirement for ICD implantation. And actually, as a task force, we were very keen to highlight this issue of shared decision-making. So particularly acknowledging that there are many challenges associated with defining specific thresholds for acceptable risk, both within an individual cardiomyopathy phenotype, but also across the different phenotypes. Certainly, the shared decision-making should be based on real-world data that takes into account individual preferences, different circumstances and values, but importantly, that highlights and acknowledges gaps in evidence and shares these with patients, and also takes into account competing risks, so risks related both to the underlying disease process, but also to the treatment that's being considered. And finally, and crucially, we call for the development of decision aids that are tailored specifically to patients and carers to help us communicate these issues around risk in a much more robust way. And of course, this doesn't just apply to hypertrophic cardiomyopathy, but it applies across all cardiomyopathy phenotypes. And perhaps the underlying phenotype in which the greatest changes are seen and where this shared decision-making process is perhaps most important is dilated cardiomyopathy. So here we've tried to move away from the use of left ventricular ejection fraction as the sole arbiter of risk in dilated cardiomyopathy, and are keen in particular to highlight the importance of genetics and the patient's genotype. So this is a new 2A recommendation that the patient's genotype should be considered in the estimation of sudden cardiac death risk in patients with dilated cardiomyopathy. And so for patients who have an ejection fraction of greater than 35%, but have a high-risk genotype and additional clinical risk factors, that's now a class 2A indication for an ICD. And even in the absence of additional clinical risk factors, the presence of a high-risk genotype remains a class 2B indication, so an ICD may be considered in this context. And even in patients without a high-risk genotype, but who do have additional risk factors, so for example, extensive late gadolinium enhancement on cardiac MRI, cardiac syncope, and an ejection fraction greater than 35%, that's also now a class 2B recommendation. So an ICD may be considered in this situation. And so this is what the new algorithm for dilated cardiomyopathy looks like, with this gene-specific risk assessment right at the very center of the algorithm. And in the guideline, we provide a table of examples of the high-risk genotypes and the associated clinical predictors of risk. And these include some personalized risk scores, such as the Lamin AC risk score. Now, recognizing that patients with these high-risk genotypes often don't have significant left ventricular dilatation. They may have slightly impaired systolic function, but they often don't have severe left ventricular dilatation. Led to this concept that Elena has, I'm sure, briefly mentioned of a new phenotype of non-dilated left ventricular cardiomyopathy. So this is a cardiomyopathy phenotype that's characterized by the presence of non-ischemic ventricular scar and other myocardial tissue characterization abnormalities on cardiac MRI. And this is the first time really that we're including features on MRI as key morphological traits for the diagnosis of cardiomyopathies. And the identification of this very specific phenotype should lead to a search for an underlying etiology, which may be genetic, but may be non-genetic. And of course, it's important to remember that many of these genotypes may have non-ischemic scar as part of their phenotype, but some may not. So some patients with BAG3 variants, for example, may not have any significant late gadolinium enhancement. But the key here is that there is a cardiomyopathy phenotype without significant left ventricular dilatation that can be associated with an increased risk of ventricular arrhythmia and sudden cardiac death. And so this is an example of this phenotype in clinical practice. This is a patient with a family history of sudden cardiac death with a left ventricle that is not dilated on cardiac imaging, with low normal global systolic function, but with the presence of subepicardial scar. Has some ventricular ectopics, and in this case, a pathogenic truncating variant in the desmoplakin gene. And so this new phenotypic description moves us away from a very simplistic approach. In the past, this patient may have been described as having dilated cardiomyopathy, but without left ventricular dilatation, or left-sided arrhythmogenic right ventricular cardiomyopathy, but without any of the diagnostic criteria for ARVC. And we now move on using this cardiomyopathy mindset approach to describe in a much more narrative way this patient's diagnosis. So we would now say this patient has an autosomal dominant desmoplakin-related non-dilated left ventricular cardiomyopathy with subepicardial scar, low normal ejection fraction. And this, of course, has important implications for management, not least in relation to sudden cardiac death prevention. And so the recommendations for primary prevention ICD implantation for non-dilated left ventricular cardiomyopathy mirror those of dilated cardiomyopathy, but with necessarily lower levels of evidence. For arrhythmogenic right ventricular cardiomyopathy, we provide new recommendations for the management of arrhythmias, both pharmacological and catheter ablation. And we provide also new recommendations for sudden cardiac death prevention. So for primary prevention, there's a class 2A recommendation that either the updated 2019 ARVC risk calculator should be considered as part of the individualized shared decision-making process for ICD implantation, or the presence of high-risk features, which may include non-sustained ventricular tachycardia, right or left ventricular systolic impairment, and cardiac syncope. It's again a class 2A recommendation. Just very briefly, for restrictive cardiomyopathy, we provide brand new recommendations for assessment and management. But what I want to highlight here is this distinction that we're making in the guideline between true restrictive cardiomyopathy and a much larger group of conditions in the pink in this diagram that are conditions that can be associated with a restrictive physiology, but often in the context of left ventricular hypertrophy. And these are not true, pure restrictive cardiomyopathies. And there are important differences in the natural history and treatment for these patients, which is why we were very keen to make this distinction. We also, in the guideline, provide guidance on assessment and management of patients with syndromic and metabolic cardiomyopathies, including specific guidance, but not specific recommendations on Anderson-Fabry disease, cardiac amyloidosis. And we also provide new exercise recommendations for all patients with cardiomyopathy. And these include 2 new class 1 recommendations. First, that regular low to moderate intensity exercise is recommended in all individuals with cardiomyopathy who are able to do so. And secondly, again, a class 1 indication that an individualized risk assessment for exercise prescription is recommended in all patients, again, with cardiomyopathy. And we also have much more nuanced recommendations for individuals with specific cardiomyopathy phenotypes, including some recommendations for gene carriers. And finally, we also provide additional recommendations on reproductive issues in patients with cardiomyopathies, recommendations on the management of patients with cardiomyopathy undergoing non-cardiac surgery, management of other cardiovascular risk factors, and also guidance for daily activities for patients and for their carers. So I think just to finish off, I think if we had to think of 5 key messages from the 2023 ESC cardiomyopathy guidelines, I think I would say that first of all, there's this concept of the diagnostic workflow, the cardiomyopathy mindset, that leads to a much more etiology-driven management approach. The recommendation for using quantitative risk scores across all cardiomyopathy phenotypes, but the real novelty here is in relation to dilated and non-dilated left ventricular cardiomyopathies. The role of cardiac magnetic resonance imaging, not just for the diagnosis of cardiomyopathy, but also for screening relatives. And similarly, the importance of genetic testing. And here, new recommendations of the use of genetic testing in childhood, so removing that lower age limit that previously existed for many cardiomyopathies, and of course the importance of genotype in risk prediction, particularly again in dilated and non-dilated left ventricular cardiomyopathies. And finally, much more specifically, I think a key message here is the incorporation of cardiac myosin inhibitors in the management of symptomatic patients with left ventricular outflow tract obstruction in hypertrophic cardiomyopathy. So thank you very much indeed for listening. These guidelines, of course, are now published. They're also available in pocket form and on the app. And there's also an official guidelines slide set that can be downloaded from the ESC website. But thank you very much for listening, and apologies again that I can't be there for the question and answer session. Thank you.
Thank you very much. I think we go for the questions and comments. Is there anyone who wants to make any question?
There was one question in the chat, but I received it personally, so that was the reason why you don't see it. And the question was from Sarah, and she asked the frequency recommendation for MRI in people with a genetic variant related to cardiomyopathy.
The frequency, to repeat it.
Frequency for MRI.
I don't think it is covered in the guidance, and it's depending on the phenotype and the symptoms, and it is written somewhere that it could be done depending on the availability of the center and of it's very difficult to generalize how frequent you have to repeat the MRI. And that was a discussion, that was a subject of discussion in many different
So the approach,
Elena?
Yeah, like Juan Ramon was saying, there's absolutely no evidence to be able to generalize a specific period of time. And there were several discussions. So the final approach we took in the guidelines was not to have a recommendation on the specific period that patients needed to be seen. In the text of the family screening, what we have is that depending on the presence or not of a genotype, a phenotype negative, genotype positive, and other individualized characteristics, the follow-up should be repeated every year and a half and 3 years, more or less. This is, we have 18 months to 3 years, if I'm not wrong, right, Juanra? Basically, we did not have data to be able to provide a concrete recommendation, and it would have been absolutely a expert opinion. It really depends on the patient and on the availability, local availability. From a practical perspective, I'd say that beyond 3 years, it does not really make sense. It's probably better to do it every year and a half, 2 years, if you don't have a phenotype, but you do have a positive gene, maybe even closer, depending on the findings that you have in the tests.
Okay, then Ruth Pilar, please.
Yes, I
Give
have
us
a
your
question about the
comments.
annual sudden cardiac death rate. I suppose it's in undiagnosed patients, the high risk mutation carriers like in DSP 3 to 5% and LMNA 5 to 10%.
I don't think it is. I think they all are, this data is taken from, estimated from published series of cases in which all of them should be affected. The no carrier, just asymptomatic carriers or non-phenotypic expression carriers. They all had to be, if they were dilated, then DCM should have been present. And in, because why is the question? Because you think they are too low, or
maybe it's because she's concerned that if we have diagnosed people and they still die, this is bad. But I think so that it's considered an estimate of sudden cardiac death is not actual sudden cardiac death. These are people with ICDs and are also people with other types of monitoring. So usually the definition of estimated sudden cardiac rate, death rate is based on documentation of appropriate therapies or sustained VT that may not lead to sudden cardiac death. This is not true sudden cardiac death, right, Juan Pablo? But it's usually done in case series with diagnosed patients, not a genotype positive, phenotype negative patients.
Okay, thanks.
anyone else? Elena?
I'd say, just to wrap up, I think the document, we didn't have much time to go into detail, but the document is the first approach worldwide, and I think that I hope we hope that it will be useful to structure so that people start thinking about cardiomyopathies. And from now on, the concept of non-ischemic dilated cardiomyopathy, for instance, is not appropriate anymore. And we do, so the key takeaway home messages are those that Juan Pablo summarized, but basically think cardiomyopathy, you have to have the cardiomyopathy mindset. Anytime you have a cardiomyopathy, CMR and genetic testing need to be done, or at least need to be considered. And then ideally, the document will help structure the process of thinking about the cardiomyopathy and how you're going to evaluate it and manage it. What we may hopefully see is actually that what we think is a rare cardiomyopathies, the prevalence that we have for the dilated cardiomyopathy may probably be an underestimation of the actual numbers. And I believe that we may become more and more important in the future to organize all this line of thought, and the ERN is the ideal place to start generating evidence, so that the next iteration of the guidelines in 5 years' time, hopefully, we'll have more B's than C's, let's say, level of evidence. We'll have more studies, more well-done studies in patients with cardiomyopathies, in risk stratification, in management, and in everything. So the next guideline hopefully will be much better than this one.
I think I want to highlight, if there's no more question or comments, I want to highlight the multidisciplinarity and multiparametric approach to cardiomyopathies, which is very valuable. And I think Ninke will agree that the value of the genetic counseling is well addressed along the document. It is not just all about genetic testing, it's more about appropriate genetic counseling and by a specific well-trained teams. The teams, the specific trained teams, this is obviously, this is something that is, it is not, it is something that is obvious in a group of ERN highly referral centers, but this is not the usual standard probably in most of the centers in our countries, in where the access to genetic testing might be increasing, but the access to genetic counseling is not that available, and imaging as well, and the implication of different specialities. That's the, and I think and take the cardiomyopathy from the very beginning. The pediatric aspect is also one of the novelties of the document that is around across the document. Well, anything else? I think we've run out of time, and we have some technical issues, but not too much. And we thank everybody for taking your time to discuss this document, and well, I wish you enjoy, and I think they're very useful, a lot of useful information in it, and that's it. Thank you very much. Thank you, Ninke, for organizing the webinar.
Thanks a lot to both of you. And thanks to Juan Kasky, of course. That unfortunately he couldn't be with us, but I was happy that he could present with his video. So thanks to everyone indeed, and hope to see you next month.
Thank you very much.
Have a nice day.
Bye. Have a nice day.